When I think about parents advocating for their kids, it seems like the road to an actual MS diagnosis can be a bit long, and because it's rare, right? There might be is there often missed opportunities for diagnosis that are
There's
happening,
lots.
and what should parents be thinking about when their kids are presenting with certain symptoms and they want to advocate to say, let's make sure it's not this? Is there an opportunity for them to do that, or is it mostly on the side of maybe the general practitioner type thing? What do you think?
Oh, it's definitely not on the forefront of most general practitioners. Will they be late to diagnosis? Yes, which is why there are very few of us, and there most of us at tertiary care centers, and it's good but there are few of those places, and most of our patients can't get there, and so, um, unfortunately, yes, there. I guess we as pediatricians we tend to know how to I'll rephrase. We trust parents. um and if a parent is coming to you and really saying this doesn't make sense and we've done ABC and I don't have an answer, then I think um we have to listen to them. And sometimes it's getting an MRI in a child should not be so hard. And it isn't, except for the fact that in a community hospital, they'll say, oh, you need anesthesia, oh, we need this. Uh, and half the time the MRIs are broken or not available. Um, we need education for the general practitioner. But at the same time, there are other diseases that I also don't want them to miss, because MS is really, um, a child isn't going to die of MS, which is great, but they will die of all the other things I just mentioned.
Yeah.
So I want them to get to me, yes, so I can treat them and help them grow and prevent relapses. But I want that stuff taken care of first.
How does the accelerated relapse rate in pediatric MS inform early treatment escalation compared to adult onset disease?
Right. It's funny the way you phrase the question, early treatment escalation. That's the problem. We don't do escalation anymore, especially in pediatric patients. They're hyper-inflammatory. They need the drug that would work the best, the fastest. Um, but the high efficacy you go, you're trading side effects. Um, and I will backtrack by saying we work, most docs out there, the general public, we work by FDA recommendations, and we only have one FDA approved medication for pediatric MS care. Why is that? It's how we design trials.
Mm.
Um, it's how the ethics of it. And we know we have medications that work very well. How am I going to put my patient in a comparator trial? That's hard. There's a different way of doing these trials, which is essentially what we have done. Most MS physicians who treat pediatric patients, we use adult MS drugs. We use pharmacokinetics and pharmacodynamics, and we extrapolate side effect data from that. We base medications on weight. We do a lot of monitoring while our patients are on therapy. So no, we don't do escalation. We don't do induction. We do high efficacy medications right away.